In our previous sketch, we outlined the pathways of lipid metabolism, detailing the various lipoprotein imports and exports around our central liver station. Keep this framework in mind as we introduce our next two classes of lipid-lowering agents, the bile acid-binding resins and ezetimibe. Like statins, these agents lead to increased synthesis of LDL receptors, ramping up LDL clearance from the circulation, decreasing LDL cholesterol levels. Unlike statins, however, these are not your first-line agents for treating hypercholesterolemia. Statins are your lipid-lowering drugs of choice, consistently proven to reduce the risk of atherosclerotic heart disease and ensuing cardiovascular events. Nevertheless, ezetimibe and the bile acid resins can be useful for reducing LDLs, usually as an adjunct to statin therapy. Again, the liver station will serve as the centerpiece of our discussion as we illustrate how the next set of agents affect the uptake and metabolism of cholesterol by the liver. Also, recall that the intestinal airbase above depicts the events that occur at the brush border of the small intestine. Bile acid binding resins and ezetimibe work by binding bile acids and dietary cholesterol, respectively, preventing their absorption from the intestine. Without these exogenous molecules available, the liver is forced instead to upregulate the synthesis of LDL receptors, pulling LDL cholesterol out of the blood. Let me show you how it works. We'll start with the bile acid binding resins, cholestyramine, cholestyramine, and cholestyramine. These agents exert their lipid-lowering effects by interrupting the enterohepatic circulation of bile acids. See this pile of gold bars here, sitting at the intestinal airbase? In this chapter, cholesterol molecules are represented by gold bars imprinted with their molecular structure. However, these ones look a little different, more bileful. A seagull is a recurring sketchy symbol for gallbladder, or in this case, the emulsifying agent stored and released by the gallbladder, bile. Notice the bile green droppings covering the cholesterol ingots. You see, bile acids are derived from cholesterol, with just a few modifications to make them more polar so that they can emulsify fats in the GI tract. Down at the liver station, let this worker here, who's depositing cholesterol payments for delivery up to the intestinal airbase, remind you that bile acids are derived from cholesterol at the liver. Specifically, hepatocytes metabolize cholesterol to cholic acid and deoxycholic acid. These lipid-soluble bile acids are then conjugated to form water-soluble bile acids, sometimes called bile salts. These bile acids are secreted into the biliary system and are eventually ejected into the duodenum via the common bile duct, ready to aid digestion in the intestinal lumen. Once they're finished doing that whole fat emulsion thing that they do, bile acids are actively reabsorbed by intestinal cells in the terminal ileum. In fact, 95% of the bile acids delivered to the duodenum will be recycled by the enterohepatic circulation. It's just like our intestinal station attendant here, not too pleased with the state of the latest payment, sending these bile-covered cholesterol derivatives back to the liver. Once they course through the hepatic vein, they're taken up by the liver where they can be reused. A nice little cycle, right? This bile acid pool is circulated 6 to 8 times per day. That is, until we throw in a bile acid binding resin. The bile acid binding resins, cholestyramine, cholestyramine, and cholestyramine, are large cationic resins that are insoluble in water. They bind bile acids in the intestinal lumen and prevent their reabsorption. The chol in cholestyramine, cholestyramine, and cholestyramine should remind you that these agents bind onto bile acids and take them to the colon, where they're excreted. In this sketch, bile acid resins will be embodied by this cholestyramine colobstyramine, a terrifying yet undeniably awesome steam-powered lobster that's preventing the return of bile acids to the liver. Here's what happens when you interrupt the enterohepatic circulation of bile acids. Normally, all those bile acids that return to the liver exert negative feedback on bile acid synthesis. In other words, the liver station workers are all like, whoa, we don't need to synthesize our own bile acids, let's just use these ones. However, when bile acid resorption from the intestine is inhibited, the liver has to upregulate the conversion of its own cholesterol to form more bile acids. And now look what you've done. You've consumed all of the liver's cholesterol stores. One way the liver compensates is by increasing the activity of HMG-CoA reductase, the crude ore reducer responsible for producing some shiny new cholesterol currency. In other words, cholestyramine, cholestyramine, and cholesevelam actually increase cholesterol synthesis by the liver. Cholesterol that is diverted toward the synthesis of new bile acids. Here's the good news though. Besides ramping up endogenous cholesterol synthesis, the liver also upregulates the number and turnover of LDL receptors. This enhances the clearance of LDLs from the circulation as the liver utilizes the cholesterol on board these LDL vessels for continued bile acid synthesis. Just think of these load-L receptor workers getting activated because their supervisor is not too pleased about the liver's depleted cholesterol stores. Remember from our statin punk sketch that LDLs are the cholesterol-rich lipoprotein transporters responsible for delivering cholesterol to tissues. It's these same LDL cholesterol carriers, however, that can also sneak into arteries and cause atherosclerosis. Cholestyramine and the rest of the bile acid-binding resins are used in patients with primary hypercholesterolemia, producing an approximately 20% reduction in LDL cholesterol in maximal dosage. Remember, however, these are not your first-line agents for reducing LDLs. Statins are your lipid-lowering drugs of choice, consistently proven to reduce the risk of atherosclerotic heart disease and ensuing cardiovascular events. Nevertheless, the bile acid-binding resins are sometimes used in conjunction with statin therapy. One of the undesired effects of bile acid resin therapy is an increase in serum triglycerides. Recall that in the setting of impaired enterohepatic circulation of bile acids, you've got all this ramped up synthesis of endogenous bile acids. Well, the hepatic production of triglycerides and VLDL is increased as well. Remember from our previous sketch that VLDLs are your triglyceride-laden lipoprotein transporters, exported from the liver, responsible for delivering triglycerides to tissues. And in this chapter, VLDLs are represented by the very low-density airships that transport these triglyceride trident-wielding passengers from the liver to the peripheral sites. Well, see how this cholestyramine lobster frightens the triglyceride passengers as they scramble onto the departing VLDLs for safety? Just remember that cholestyramine causes increased production of VLDLs and increases the levels of circulating triglycerides. Because of this tendency for bile acid binding agents to increase serum triglycerides, they should not be used in hypercholesterolemia patients who have concomitant hypertriglyceridemia. In other words, they're really only helpful for treating isolated increases in LDL. Another adverse effect to watch out for is the development of gallstones. In the face of all this ramped up bile acid synthesis we've been talking about, the liver is throwing all kinds of cholesterol and cholesterol derivatives into the biliary tract. Thus, the cholesterol content of bile rises, increasing your risk for cholesterol gallstones. So we've sketched in our recurring symbol for gallstones, the C gall, providing some counterbalance to this stack of stones. The main side effects of bile acid resins are gastrointestinal upset, commonly presenting as constipation and bloating. Notice that we've made our cholestyramine lobster latching onto this intestinal pipe, impeding the flow. Therefore, resins should be avoided in patients with diverticulitis, for example. In patients who have pre-existing bowel disease or cholestasis, steatorrhea may occur from impaired fat absorption. This can lead to reduced absorption of fat-soluble vitamins as well. Remember that ADEC represents your fat-soluble vitamins, A, D, E, and K. So we've labeled the intestinal docking station DEC-A. Malabsorption of vitamin K occurs rarely, but remember that this is the vitamin responsible for producing factors 2, 7, 9, and 10 in the clotting cascade. So in patients who are taking resins along with an anticoagulant like warfarin, a vitamin K antagonist, you've got to watch out for excess anticoagulation. Absorption of numerous drugs can be impaired by the resins, including digoxin, thiazides, warfarin, aspirin. The one to really watch out for is statins. Remember that bile acid binding resins are primarily used in combination with statins. However, concurrent administration of these two drug types results in decreased statin absorption. Just think of our colobsteramine lobster and our statin punk pirate at odds with each other up on deck A. For this reason, it's recommended that these agents be administered at least 4 hours apart. Okay, break it up, you two. We're going to introduce one more lipid-lowering agent in this sketch, ezetimibe, represented by this cool, shiny, alternate 1800s reality steampunk eel. Ridiculous, yes, but pretty badass nonetheless. Also, it's Z-shaped. Think ezetimibe, the Z-shaped eel. Ezetimibe is similar to bile resins in that it binds molecules in the GI tract, preventing their absorption. However, while the resins were binding bile acids and interrupting enterohepatic circulation, ezetimibe works by inhibiting intestinal absorption of dietary cholesterol. This is depicted by our ezetimibe eel, blocking this new delivery of exogenous cholesterol cargo at the intestinal station. Recall from our last sketch that the cholesterol and free fatty acids from the intestinal lumen are packaged onto chylomicrons, these lipid-laden hot air balloons responsible for delivering triglycerides to peripheral tissues. Well, throw in an ezetimibe eel, and you're not going to be able to load much cholesterol onto those chylomicrons departing for the circulation. Once chylomicrons are depleted of triglycerides at peripheral tissues, they're taken up by the liver as chylomicron remnants. Normally, they're endocytosed at the LDL receptor, and the cholesterol on board can be used by the liver either for production of bile acids or for repackaging for export onto VLDL carriers. Take a look, however. No cholesterol made it on board this chylomicron, and it looks like the boss isn't too happy about the reduction in cholesterol shipments. Ezetimibe effectively restricts the liver's access to exogenous cholesterol, and this leads to clinical effects similar to the bile acid binding resins. In response to depleted cholesterol stores, the liver must ramp up its own production of cholesterol. So again, this means increased HMG-CoA reductase activity, depicted by the workers frantically ramping up cholesterol currency production at the crude ore reducer. Also, just like with bile resins, to get more cholesterol, the liver upregulates the activity of LDL receptors. Let's sketch in a threatening ezetimibe eel in the water below, prompting the liver station workers to increase the clearance of those cholesterol-laden LDL transporters from the circulation. We've sketched in a shipwrecked LDL vessel as well as a little extra reminder that LDL reduction is the goal here. However, I want to reiterate, statins are your lipid-lowering drugs of choice, consistently proven to reduce the risk of atherosclerotic heart disease and ensuing cardiovascular events. Ezetimibe is a newer agent, and its ability to reduce hyperlipidemia-related mortality remains unclear. Nevertheless, they are sometimes used in conjunction with statin therapy, further reducing LDL levels as much as 25% beyond that achieved with statins alone. Just a couple side effects to mention. Ezetimibe doesn't cause the gallstones or that weird increase in triglycerides like the resins. All you need to keep in mind are rare increases in transaminases and diarrhea. So let's sketch in some muddy, oily water emanating from our steatorrhea-inducing friend. Also, elevated transaminases will be represented by our struggling passenger here, thrown overboard and signaling his friends with that recurring LFT flag. I don't think the signal is working. Alright, before we bring our second steampunk chapter to a close, I want to briefly mention one of the newest classes of lipid-lowering agents, proprotein convertase subtilisin kexin type 9, or PCSK9 inhibitors. Okay, I know it's a mouthful, but let's sketchify it instead. One agent in this class is called evolocumab, which sounds kind of like an evolocumab octopus, so we've included this cool Dr. Octopus looking guy at the LDL receptor. PCSK9 is a protease produced by the liver that leads to the degradation of hepatocyte LDL receptors. Block these proteins, and you're better able to keep those LDL receptors around. Think of it as Dr. Steampunk over here removing these pesky PCSK9 crabs from the dock workers. Notice that we've incorporated a 9 into their shells. Also, take a look at the claw contraption used by Dr. Evolocumab. They depict IgG molecules because many of the newly developed PCSK9 inhibitors are antibodies that selectively bind to this protein. Therapies that lower circulating PCSK9 levels significantly lower LDL levels, and this category of lipid-lowering therapy appears promising in a range of clinical situations. All right, let's sum up this sketch. The bile acid resins and ezetimibe both work to reduce circulating LDLs, though statins are your first-line agents for this purpose. The resins, such as our colobstearamine lobster, interrupt the enterohepatic circulation of bile acids. When bile acids are blocked from reabsorption in the intestine, the liver is forced to make its own. It does this two ways. It upregulates HMG-CoA reductase, as depicted by our activated crude ore reducer, and it upregulates LDL receptors. This leads to increased uptake of LDLs out of the circulation. One weird side effect, cholestyramine actually increases serum triglycerides floating around on that VLDL airship. The main side effect to keep in mind is gallstones, as the liver throws too much cholesterol into the biliary tract. Up at the intestinal platform, we also show the possibility of reducing fat-soluble vitamin absorption. Ezetimibe binds cholesterol in the intestine instead of bile acids, with similar clinical effects. The cholesterol-starved liver upregulates LDL receptors, clearing LDLs from the circulation. The most important side effects are diarrhea and elevated LFTs. Alright, you thought these steampunk creatures were terrifying. Wait till you see what the Loch Niacin monster has in store for your HDLs.